All right, well, hello everyone and welcome to our webinar this afternoon or this morning, depending on your time zone. My name is Abram Rosenblatt. I'm the Project Director for the Child Mental Health Initiative National Evaluation, and I'm coming to you from lovely Rockville here in Maryland, and I'm with Westat. We have a great panel for you today, and we're going to be talking about approaches to evaluating services for youth and young adults of transition age. In a moment, I'll introduce all of the presenters, but let me just take you through the next couple of slides first. This is our disclaimer, and we just wanted to make sure that you all understand that this is hosted by us at Westat. It was prepared under a contract with HHS and SAMHSA, and these views do not necessarily reflect those of CMHS, SAMHSA, or the U.S. Department of Health and Human Services. These are the objectives of the web event. We have Yoda over here helping you out. We hope you will learn about different types of data, including service quality outcomes, system effectiveness, that programs serving youth and young adults often collect. We hope you also learn about the considerations and trade-offs that are important when deciding about what data to collect and how to collect it. We'll give you an example of the Oh Yeah evaluation, which is a great name for something, and how it responds to key considerations and also covers a variety of different types of data. And we'll also have youth and young adult perspectives on evaluation and participation in evaluation. As I mentioned, we're really fortunate to have a great group of presenters today. Janet Shakuntala Walker is a research professor in the School of Social Work at the Regional Research Institute at Portland State University in Portland, Oregon. She is the director of the Research and Training Center for Pathways to Positive Futures, which is focused on improving outcomes for older adolescents and young adults with serious mental health conditions. She's also co-director of the National Wraparound Initiative and is the recovery lead for the Region 10 Mental Health Technology Transfer Center, among many other things. In general, Dr. Walker's research aims to improve outcomes for children, youth, and young adults with serious mental health conditions through rigorous research and program evaluation. Our next presenter is Mary Beth Welch, and Mary Beth is a peer support training specialist with the Research and Training Center for Pathways to Positive Futures. She has lived experience as a young person in the mental health, foster care, and special education systems. She uses that experience to guide her work as both a youth peer support specialist and a peer support specialist trainer. Finally, we have Penina Goldfarb. And she is a research consultant since 2009 for Wraparound Milwaukee, a longstanding program that serves children, serves system and non-system youth who have been diagnosed with mental illness, and was part of the startup team who designed the Oh Yeah program. She has over 40 years of experience with children and youth who experience mental and behavioral health issues in a breadth of professional arenas, including public and private schools, hospitals, clinics, and universities. With this wealth of experience, she has served as an educator, teacher, trainer, school consultant, curriculum developer, and researcher. So at this point, I'm going to get off. I'll see you all at the end. We'll have a discussion at the end where you'll be able to do some chat and get some questions answered. So please feel free to type those in as we go, or at the end we'll type them in, and we'll do that. And otherwise, I'll turn it on over to our presenters.
Okay, well, thank you, Abram. This is Janet Walker, and Mary Beth and I are going to be kind of tag teaming here on covering the first couple of objectives that are part of the list that you saw just a moment ago. Before we get too far into it, though, I do want to draw your attention to this issue of Focal Point, which is a periodical that is put out by the Pathways Research and Training Center. And the current one focuses on evaluation topics. And so I'm going to be referring to articles in there periodically as we go through. And if you're interested in finding out more, you can then access Focal Point and take a look at some more detail behind each of those. The current issue, in fact, focuses on evaluations that are being done by grantees under the federally funded, actually SAMHSA-funded, Healthy Transitions grant program. And many of the communities are using grant dollars to build on or enhance their own ongoing evaluation capacity, and then they wrote these articles for us about it. And Project Oh Yeah that Penina will be talking about is one of these. You can see that they have also contributed an article to the Focal Point issue. Next, please. If you're interested in accessing Focal Point, you can do that on our website. You put Pathways RTC into your browser. Additionally, there are a number of the subset of the measures and assessments that we'll be talking about today. I'll mention these in particular that you can get from us if you're interested in them. And we also have various other resources, including an e-newsletter, I suppose, list that comes out that you can find out more about the research that we're doing. All right, so the first thing I wanted to talk again, that sort of first point under the objectives, is sort of discussing a number of the different kind of buckets of types of data that are often collected in programs that serve youth and young adults. Oh, I'm sorry, next slide. So the first of those is what I refer to sort of broadly under the label of utilization. And that includes things like uptake, so our young people who become eligible, who are referred or otherwise directed towards your program, are they actually kind of showing up for that first appointment? After that, are they continuing to come? How often do they come? Do they no-show, et cetera? So how much service and what amounts do they actually achieve? And obviously usually know when they stop. So to me, this is absolutely fundamental data. It's important to know if young people are coming to services enough to benefit from them, or is there some reason that they're not finding that the benefit of coming is worth the effort of attending. And it's interesting to me also that many agencies, while they, I think almost universally have most of this data because they need it for billing, don't really seem to be that aware at the program level of how things are going or what kind of stats they might have in this area. And to me, it's really very fundamental to know that. We do know, of course, that this is a very tough population to engage, so contemplating this data may not always be like a super fun experience, but if you're engaged in trying to improve services, it's certainly important to know your baseline.
Hey everyone, Mary Beth here. I forgot to put in my bio that I have been a participant in research projects when I was a young adult in the systems that were mentioned, and also I've worked on research projects where I was the one doing assessments. So that's kind of my experience around assessments and evaluations. But right now, I want to talk about it's important when you're looking at disenrollment to kind of have some ideas of measuring why that happened. Was it because of successful completion? Was it because of planned completion? Maybe not like meeting treatment goals, but there was a timed ending. Maybe the person stopped contact, transferred to other services, that kind of a thing. Maybe you don't need to know all of that information. Of course, that information is good, but maybe it just needs to be like, was there a successful completion, yes, no option. That's all I've got for that.
Good, thanks. Okay, so the next bucket generally...
Next slide.
Oh, sorry, yes, thank you. Next slide, please. So the next bucket generally, you can see we have a very satisfied pup there. So many of the programs that we encounter serving this population do some level of satisfaction data. Often that might take the form of surveys of participants or focus groups. The kind of next sort of subcategory within the service quality more generally is trying to look at aspects of program fidelity. Of fidelity, and that can include, in my mind, again, sort of two subtypes of fidelity. Fidelity being the extent to which your program actually replicates the model that it's aspiring to replicate. So program and structural things, often this can be done through sort of checklist items or a kind of internal audit of the program to find out things like, are the caseloads what are recommended for this project? Do staff that are serving young people have the qualifications that they need, et cetera? Practice fidelity is really much more focused on the actual interactions between a young person and provider to see whether they really are following the model and utilizing kind of whatever the active ingredients are that are part of a specific intervention. Again, to my mind, it's super important to be seeing that because otherwise it's very difficult to know what's actually going on. And fidelity assessment in this case would be done through either a live observation or video or audio recording and would be assessed with some reliable structured approach. There are approaches that do fidelity with kind of checklists or surveys, but to my mind, those are really function more like satisfaction measures, not really getting at the nitty-gritty of the quality of interaction and whether that mirrors the program expectations or the intervention expectations. It's certainly possible to do kind of broader kinds of, typically these are things that are done by survey to see whether the program generally, and I'm thinking of, again, the youth and young adult population, often they are expected to kind of adhere to an empowerment orientation or a youth and young adult driven, and there are various assessments that can get at this sort of in a general way, and these are usually typically surveys type approaches.
It's important to have all of these types of information, so it can be easy because you don't want to have too long of an assessment or survey or whatever to kind of pick and choose, so it might be easy to be like satisfaction, okay, we don't necessarily need to measure for that if we're making sure that all of the principles are being met because we know that that leads to satisfaction in our services, but maybe that's not true anymore. So it's very important to focus or to make sure you have a focus on each piece here. Next slide.
All right, so just moving on very quickly to the next bucket, which is a huge one, which is outcomes. And there are typically, I would say, when we are encountering programs for youth and young adults, they really have a wide span of outcomes that they're looking at, and because the needs of, especially the higher needs population are kind of broad, and so services, often the service response is also sort of aspires to be quite comprehensive. So there are different ways of getting at this. Some of them can be indicators where you can sort of check off one or of a number of particular responses, and that might be, are they employed, none, full-time, part-time, are they in school or training, et cetera. So those can be just sort of one item, but certainly can be very powerful. And then there are just a multitude of standardized assessments, and they run the gamut from 3-item questions to multi-part, multi-dimensional outcomes, strengths, and all that kind of stuff. I'm not really going to talk about specific ones here, where we'll talk a little bit later about how you might decide when and how to use those, but it's important consideration is whether they are acceptable to youth and young adults, and particularly also whether they are validated for that population. Then certainly programs, and you would see if you looked across the focal point articles that are in that issue, a variety of kind of non-standardized assessments that people use. Often these can be things like single questions that are really based on kind of being face valid. Do you feel safe in your current housing environment or something like that? People also are quite free, I would say, in adapting or reducing scales. And I don't necessarily see that there's a big problem with this, but, of course, you have to be aware of when you're doing it, and of course, it's always helpful to be intentional about exactly what adaptations you might make. And then finally, there's a set of an approach that I would call individualized outcomes. I think we'll be hearing quite a bit about this, both because I hope to talk about it later, and also because I think Padina will be talking about it. But essentially, this means that a client comes up with the goals that they have for themselves that can be met through the program's activities, and they start out at the beginning and give themselves kind of a rating on maybe a 2, and then with their therapist or care coordinator or peer specialist later on, they'll go back and say, well, I'm still working on this goal, and now I feel like I'm at a 4, something like that. Next, please. And then this one is just sort of a miscellaneous bucket, and partially because we have developed our own measures in some of these areas. So sometimes you want to know how well your system, either at the local level or the state level, is working kind of as a whole, particularly in areas like collaboration across systems, ease of moving from one service to another for young people, whether services are available. You may also be interested in understanding whether there are actual structures in place to promote good system functioning. For example, some kind of collaborative group across the providers that are working with this population to help kind of cross-referring, to help identify service gaps, to potentially have a shared training plan, et cetera. And we do have a measure that we developed here that was actually used and validated in a previous cohort of the Healthy Transitions Initiative that you might be interested in. They're at the community level, Community Supports for Transition Inventory, and the State Supports for Transition Inventory, with the latter kind of looking at how well is the state working in kind of an intentional and coordinated way to help the communities provide basically a coordinated and comprehensive system of care for transition-age young people. Next. So that's just supposed to be amusing. So if you are, I also skipped over, I am sorry that I didn't mention the one other thing that we have been working on with Youth Move, next please, is this youth voice at the agency level and youth voice at the, on councils and committees. And these are assessments that are looking at the extent to which agencies and councils have adopted best practice for ensuring that young people that they have invited to participate with them in decision-making and governance are actually being supported so that they can have influence and also so that they are not excessively stressed out and exploited during that process. So if you're interested in understanding or learning more about those measures, you can contact Youth Move on their website and get access to them. Next, please. Okay, so moving on to the next piece, that was where we promised that we would discuss sort of considerations to how do you decide with all of these different choices and many different kinds of assessments. How do you pick the ones that you're going to use? And so I made up this little mnemonic that says the best data is data you use, which I think is actually very true, and sort of clump this discussion under some general topics that data should be useful, unobjectionable, sustainable, and efficient. So I'm going to just quickly kind of touch on those, each one. So if we can go to the next slide. Useful. Top consideration, I think, is data that stakeholders care about. If they care about the data, it will increase the chances that it will actually get collected. And I think that applies equally to staff who are maybe administering these assessments, as well as young people who are the focus of assessment. And there's a nice example in Focal Point that describes the way that one program used focus groups with young people to find out the outcomes that they valued. And as a result of their work with these young people, they started to focus on collecting some wellness outcomes, which I think is actually a very typical thing that young people want to focus on. And they felt in their program and from the feedback they got from the young people that collecting this along with the other data helped the young people feel that the program would see them as a whole person rather than, this is a quote from the article, just a collection of symptoms and problems. Next, please. Another thing about useful is that young people may be more willing to participate in evaluation when they feel that the point of evaluation is to improve services. And this was something that we took to heart very much when we were, I was part of a group that was working on the national evaluation of a previous cohort of Healthy Transitions Initiatives grants. And we felt that it was really important if we were going to get participation by young people to help them understand that what we really were looking at was improving the grant program, improving services, finding out what works, et cetera. And so we enlisted a young person from Massachusetts who did actually a very funny and engaging video about why this was sort of the frame for the evaluation. So I think maybe you wanted to add some stuff there.
Yeah, so I wasn't a part of this project, and I learned about this video as we were preparing for this webinar. But I think that that's a super cool idea. I've participated in feedback-informed treatment when I was in therapy, and then also, like I said, have been a participant in a research project where there were very, very long assessments that were done. And I'll be talking more about that later. But I think that I would have been a little bit more engaged in it if there had been a video kind of explaining what's the point of this. So I think that's a super cool idea. And it also would have kind of driven home the idea of feedback-informed treatment is to improve services. When I have taken part in that for therapy, it was just a paper, and again, it was not through this project, but it was a paper of like checking off how did my last session go on a scale, and how is my relationship with my therapist on a scale, kind of a thing. And I'd fill it out and hand it to my therapist at the beginning of a session, and she'd say, thanks, not look at it, and just put it in her notes for me. And it didn't feel valuable. So I think that having a video book to engage the youth and young adults, and also maybe even a video to engage the people who are providing the feedback-informed treatment, and explaining the importance of that could be really, really helpful.
Thanks. Okay, next slide, please. So continuing on in a sort of general theme of usefulness, again, slight variation on the previous slide is that stakeholders are more likely to be engaged in all of the data gathering activities if they actually see it being used. And that kind of gets back to Mary Beth's point about if you're collecting data about for this feedback-informed treatment, which is basically a very short questionnaire, either immediately prior or post a service encounter, that if it's apparent that nobody's looking at that, I feel that that's almost worse than not doing it at all, and may lead people to be very cynical about data gathering in general, and even to do stuff like put down, well, they don't care, I'll just put down whatever here. And definitely as an evaluator, you can see instances when you're cleaning your data of people putting down whatever. So you don't want to have that happening. So this was a very common observation from the Healthy Transition site, because I do think that the young adult population is perhaps the most difficult to engage in data collection and in treatment, as we sort of were talking about before. In addition, it can be difficult to engage staff in data collection if they don't see the point of it, particularly if they feel like they're collecting all sorts of stuff that nobody ever looks at. So there's a nice example in the focal point of Thresholds, which is a large provider organization serving this population in Illinois. And they had engaged their staff in sort of projects of quality improvement where they would identify a specific area that they might want to do some work in, identify some data elements that they were collecting that would help them evaluate that, or maybe get some new data, do something different, and then see whether the data reflected that change. So that, as they reported, was very engaging for their staff. And I think also, I have this up here all over the place, I realize, but the feedback-informed treatment project, this was not the one that Mary Beth was participating in, but they have really been able to engage staff in that process by making it a focus on, they particularly have brought in a focus on suicide reduction, and they ask a couple of questions, and so that's another target that has engaged them because it's an organizational and a staff priority.
Along with the video in the beginning, I think like letting the youth and young adults know feedback from the data as it's being used over time can be helpful for engagement in the assessments as well. So that could be something along the lines of over time, if you're not doing just a beginning and an end kind of thing, if you're doing middle assessments as well, kind of being like, we got feedback from a number of youth that this is not working, and so here's how we're working to change that. That kind of thing. Using the data and also showing how it's being used can really help with getting more good data.
Mm-hmm. So reporting out to stakeholders, including young people who are part of the program.
Yeah.
Cool. Next slide, please. Another way to make the data more useful is to collect common data elements across the sites and programs. A lot of times what we'll see is that similar data is being collected, even, say, across sites that might be funded by the same state or the same funder, which makes it not very easy to compare what's going on. And being able to compare, I think, provides a lot of advantages, particularly allows for greater learning if you're able to compare and see, well, one site's doing a particularly good job with this, but what are they doing, and can we move it to the other site that's not doing such a good job? I think it's also pretty crucial for accountability. If everybody's just doing their own thing and measuring it their own way, it becomes very difficult to establish any kind of benchmark or expectation. And there we have some examples that you can read about in Focal Point of how people are doing that. Next, please. Okay, moving to the next bucket, unobjectionable. So again, it's pretty obvious, I guess, that evaluation participants are not going to be so eager to participate in your data gathering or give information that is accurate if it feels shaming or if it feels like for some reason it could lead to punishment. And I put that in quotes because I don't mean that anybody's going to flog them or throw them out of services, but it may be that the consequences that flow from giving accurate information are actually kind of aversive to participants. I think that, again, throughout the Focal Point issue and certainly in my own experience, that young people can often feel sort of shamed, particularly when they're questioned about alcohol and substance use, housing, or the certain times of their social connections and other things, where if they don't have stuff, maybe they feel shamed, or maybe because of the way that they're leading their lives in ways that they might feel is quite reasonable, but they feel that the questions are asking in kind of a judgy way that implies criticism. I think that it's also, if we think more broadly about this issue, that staff, anybody who feels that they're being assessed can feel nervous, uncomfortable, or shamed by that. And it's certainly possible that if you're doing this form of feedback-informed treatment or observational, that you have to do it in a way that doesn't lead to people feeling shamed by it. Similarly, staff and administrators often maybe don't like to scrutinize themselves or be scrutinized too carefully because they feel that it will lead to some similar kind of punishment or shaming for them.
So I have experience with, again, taking assessments and giving assessments. And a problem that I've always run into as I've taken assessments, so like I said, I was a youth and young adult in the mental health system. I dealt with suicidal ideation often. And often when I was taking the assessments or doing the feedback-informed treatment, which had those suicide trigger questions of like, have you felt suicidal in the last 6 months or something like that, pretty often I could answer yes, but I would not, because there were natural consequences to answering yes to that question, such as suddenly they have to notify your caseworker, because I was in foster care, so they have to notify your caseworker. It becomes a huge deal. Your foster mom gets notified, like all of this stuff. And that's important as people providing treatment to help make sure that we're giving support to suicidal youth. Like, we don't want anybody to die on our watch. But also figuring out some kind of way to do it in a way that's not stigmatizing it is really important. I don't have a whole lot of solutions for that, but there is a problem. Like, I just have that as a potential problem. It might be something like recognizing that having a fail switch question, I don't know if that's the right term, but like, where do you also have a safety plan in place and you have adults who know that you're dealing with this? Because a lot of the time when I was experiencing suicidal ideation, I was working with a therapist. My caseworker already knew. My foster mom and I had a support plan. I had a safety plan. I had a self-care plan. I'd been in treatment, but I still knew that I was going to have to go through unnecessary hoops if I answered yes to this question. And so it wasn't worth my time, so I was not giving accurate data. So having some kind of way to make the reaction to that still supportive and also like helping youth who are suicidal and actively suicidal, but also having it so that it's not going to have big consequences to somebody who's already accessing support for it is important.
Thanks. Next slide, please. So here we just have a few tips, some of them coming directly out of our famous focal point issue, about how to make things less objectionable. So one of the ways, and this is explored in the article you see, there's an image from it on the right-hand side there, that the program in Wisconsin that reworded their alcohol and substance use items in order to make them more palatable and less judgy sounding. You can also change your method of data collection. Sometimes when it's collected by a peer versus a caseworker might feel different to a young person, or by doing it online. I think young people, maybe all of us, tend to see computers as pretty neutral, or by third-party data collection. And then, of course, it's really important and definitely easier said than done is to really genuinely have a strengths approach when you are working with people and evaluative data. And I'm thinking particularly if you are working on doing observations of staff or doing this kind of feedback-informed treatment, that it needs to be presented to staff as a learning opportunity, and it really needs to be seen genuinely throughout the organization as such. Similarly, when you go to be doing organizational performance, or if you're sort of starting to really take a hard look at your no-shows and your dropouts and how many people you successfully have completing treatment, you know, you want to recognize that this is a problem that's pretty much everywhere, and that it's better to take a hard look at it than to stick your head in the sand. So next slide, please. Efficient. Okay, so we're down to the next one, which would be, again, kind of going back to useful in a way that you need to really prioritize the constructs that stakeholders value and that your program will impact the most. So again, there's this whole universe of possible assessment that you can do. If you're sort of starting from scratch, or if you're trying to winnow it down, you need to talk to your stakeholders and figure out where are we making the biggest impact. And then, sort of by the same token, you need your indicators to actually get at those constructs. So some things that may sound good in their title of what they're getting at, when you actually look into them, either turn out not to be very sensitive. And I'm just going to give a simple example that has come up a number of times, which has to do with how you look at housing for young people. That there can be sort of categories, and I'm thinking particularly of one that might encompass living with friends and relatives. It's often kind of one of the housing categories. And this is a program, if you're working at a program and you know that you've taken a young person who's living with sort of a bunch of sketchy roommates in a dangerous situation and moved them into housing with a relative, say, that's permanent and feels safe, that's a huge achievement, but it's still in the same category of housing. So if that's what you're relying on, it's not sensitive to important changes. So again, that article from Wisconsin has some interesting information on that one. I would say sometimes the categories that you might use for what's problematic versus not substance use is another area where you can make huge improvements that feel like an improvement to the youth, but may not be captured given the type of tool or the indicators that you're using to measure that. Next, please. Oops. Efficient. Yeah. Okay. So this is a huge one, and I have one short slide on it, but basically you need to use indicators that get at constructs without a ginormous amount of effort. There are, as we mentioned before, massive assessments that can be used, and there's a temptation to want to measure everything since our programs are comprehensive. But there are ways to use single indicators or small numbers of indicators versus much longer assessments. There are ways to do periodic assessment versus collecting the data ongoing all the time. Often, say, a Fidelity probe or exploration might just be done in a couple of months at your agency. Satisfaction data doesn't necessarily need to be gathered all the time, maybe just periodically, or focus on a specific program or group of young people, subset during a particular time period. Collecting data at the time or as a part of service delivery, I think, is a very useful strategy because it doesn't increase burden, really. If we go back to that, I was talking about the individualized goal setting. That could be a very integral part of the of the collaboration between a young person and service provider, so it's just naturally something that you're checking in on as time goes by. You know, how are we doing on these goals? Let's give them a number, and then it's done. Similarly, the feedback-informed treatment, it's done at the time. It's designed to be very, very short, so it takes a couple of minutes at the most. So you kind of have your captive audience there, so it's easy to ensure that the data gets collected. I do want to say that as much as I'm as a proponent of being pragmatic about making these trade-offs, I do want to caution that it's not always a great idea to be excessively pragmatic. I think in some cases, for example, I think the main thing that I'm thinking about here is not to rely exclusively, say, on the therapists or the care coordinators to provide the data on outcomes for the young person, and believe me, this happens. I think they're fine to have some data from them, but if you're not talking to your youth at all about their outcomes, I do see that as a problem.
So a lot of this comes down to don't be a data hoarder. It's really important to get at the data that you need, but if you find yourself thinking, well, maybe we'll look at this later, ask yourself whether or not you really need to look at it later, or if you can get the information later. So I'm saying this because when I was a research participant, this was when I was 16, 17, so I was both in high school and working and doing various treatments. I had to take part in, well, I chose to take part in the research project, but part of that was doing assessments, and these assessments were really, really long, like an hour and a half or longer if it took me longer. That was the minimum time that it took. And it was similar with the assessments that I gave when I was working on another research project. Really long, right after school, like when my brain was dead, like just over it kind of stuff. And snacks are helpful and everything, but still try to be efficient about your time and don't make them that long, because once it goes on long enough, it's hard to get good data. It's hard to get somebody to stay bought into it for that long. So really consider what are you using, what are you going to use, and don't try to get everything perfect.
Thank you. Next slide, please. So I also want to sort of put a plug in here for individualized assessment, and going back to that sort of rating of the goals. I think, you know, part of the problem is, again, we're providing comprehensive services, but if you want a comprehensive assessment, that could be huge. The other problem is that any given young person is only working on specific of those maybe life domains. So if you find that only maybe half your youth are working on an education goal, if you take the data for all of them, you're going to be diluting your findings and the evidence of the impact that your program may be having. So I actually want to put in a plug for this individualized approach, where you have young people determining their own goals and rating the extent to which these are being achieved. I do want to say, though, that this has to be done in a fairly structured way. There is a process that you may have heard of if you're an evaluator, it's been around forever, called goal attainment scaling, and that is super elaborate, and I believe that most agencies and organizations that are currently doing this on a sustained basis don't do the full-on process. On the other hand, it does need to be, if you really want to use this data and argue that it's reliable and valid, you want to be able to do a structured process that's more than just saying, okay, what are your goals? Let's stick some numbers on those. So I think that can be very helpful. I mean, again, you can also just do, suppose a young person identifies a specific goal, say an education goal, then you give them the education questions, and otherwise you don't. And that was the approach that was taken in at least some of the evaluations that are written about in the focal point article. All right, next slide, please. Obviously, you wanted this to be your data. We're on the last topic, sustainable. It's really helpful if you can use data that's already being collected, because that's sustained. And sometimes it's just a matter of paying someone to produce different kind of reports out of that existing data, and or bringing those reports to more general awareness than before. Next, please. Again, different data collection strategies can definitely make it much cheaper and easier to gather data. I'm not going to talk a lot about REDCap, but if you're thinking about building a giant data electronic health record or some other data thing, that I know in our state it's a project that can take years and millions of dollars and often really not even turn out that well. I would suggest you might want to look into REDCap as an alternative, which is a little bit more do-it-yourself but very secure and well-regarded platform. You can use phones and tablets to gather data. Again, doing it as a part of a kind of an integrated part of services or training and coaching. And I think that brings us in a rather timely way to the end of our presentation. Mary Beth, any closing remarks?
That's all I've got.
All right, well, we're going to turn it over to Penina. Thanks, everyone.
Hey. Hi, everyone. I want to start by saying that the OEA program has been around for over 10 years. It started with, I believe it was in the second round of the HDI grants through SAMHSA. So we've had a long history at this point. Next, please. Next. Everything emanates from our beliefs. First, we believe that our wraparound values and principles has provided direction in designing our program. They drive our program practice and finally serve as a compass for our program, ultimately meaning evaluation. As I hope you can see by this slide, we also have strong values and beliefs around the evaluation process itself. It's intertwined with our practice model values and principles, and we call this scientific mindedness. Without assurances that we are being true to our practice model principles, we could not go on to evaluate the program. So essentially, we're talking about Fidelity as a strong emphasis in our program. We also believe that wraparound and OEA have good outcomes, and they have good outcomes because we're responsive to the data that we gather and look at on a regular basis. That creates a program that's dynamic and fluid and always keeps us in the mode of trying to improve and do better. And obviously, good outcomes result in cost savings and stakeholder satisfaction. Next. So we know, if we talk about scientific mindedness, we know it's important to know why we are doing it, values and theory, stay on how we're doing the things we're doing, process and fidelity, and determining what is working, which is ultimately our outcomes. These action-oriented principles of scientific mindedness align with Janet's outline of types of data, specifically service quality, fidelity, and program outcomes. Next. So to answer to the first principle of why it's all based in our belief system, and I'm not going to go through the whole values that is supported by OEA, but you can see that what we did is we believed in OEA, and then we went ahead and traded out particular values that I think are developmentally appropriate for our young adult population, domain-driven and person-centered versus family-centered and needs-driven. Next. To further support the concept of our belief system, it's always a good idea to have a theory of change. So based on our values and principle, which lays the foundation, we develop these strategies such as domain-driven use of peer specialists, developing a resource center. Those are the strategies, and our hopes are that based on the values and principles, if we apply the following strategies, we will get said results, which includes things like engaging, empowering young adults, having young adults actively involved in directing their futures. And you can see, I'm not going to itemize all of those, but as is depicted in these two slides, the delineation of values and the theory of change provides the rationale and the foundation of the program, and ultimately is critical to measuring service quality, and thereby answering the question of how well we are doing things. Next. Okay, we cannot truly measure outcomes without having some assurances that we are being true to the model that we believe is a good one. It would be like tasting your apple crop to determine the quality of your peaches. Okay, it just doesn't work. Next. So the first level of evaluation that we conduct in our programs, not only wraparound in general, but OES specifically, is the use of an agency performance report. And it's monitored in 6-month intervals. We use education, understanding through training, and then mostly carrots, like incentives and public recognition, and occasionally some sticks to motivate agencies to care about the fidelity of their work to assure a level of excellence in service quality. Next. So this is the APR is a kind of a rubric of what is expected to maintain a high level of fidelity to the OER practice model. And every agency that does every care coordination agency follows this approach. And if you can look at the examples on the slide, again, the reason I brought up values and the why in the beginning is because everything ties back to values. So if you can see on the top, family-driven value, it delineates the value we're looking for, and then the indicator of what we want, the performance indicator that we're requiring from the agency. So, for example, for family-driven, you can see the percent of biweekly contacts. And again, these are defined completely. So it says call or face-to-face, and at least one contact in a month should be face-to-face. And again, a threshold is established. The thresholds are determined based on a wide variety of variables, research on best practice, is it a reachable threshold? We sometimes look at the trends of what's been happening in terms of the thresholds and our agencies meeting those thresholds and determining if we have to reevaluate the threshold or change the threshold as necessary. And then we apply a scoring system, which I only indicated here. There's a lot of detail that goes into that. I've only indicated on the far right. But you can see that we look at the value, in this case family-driven, collaboration, system integration are two of the examples of values, followed by indicators, performance indicators that are beneath them. Next slide. So we have those that the previous slide identified value-based indicators, and those are one that are scored. We also have a whole array, and these are just a sample of those, of structure and process fidelity indicators that go unscored, but still maintain a standard, if you can see, a threshold that's expected. The principle is to pick what is most important. Measuring everything in great detail is overwhelming, and therefore we risk that the feelings of the care coordinators, the agencies, is that it is, as in Janet's terms, unobjectionable. We certainly have a lot of measurement, but we are still cognizant of the potential for crushing people. Our stakeholders are not only our young adults, they are also our care coordinators and others that serve our youth and young adults. Next slide. This is an example of essentially our communication system for efficiently showing how each agency is doing on both the value-based and the structure and process indicators each month. And as you can see highlighted in the colors on the left are the values themselves, and then the indicators are next to them laid out. It's not a completed example, but they can see at a glance how they did in the previous month. If you can look, you can see below the smaller box, and if they have improved, remained unchanged, or requires attention. Next. Okay, so we've discussed why and how, but what is working. So this is measuring outcomes at the service level. We have 4 different things that we measure: satisfaction through the engagement and planning tool, needs met, the domain appraisal tool, which is a modification and adaptation of the NOMS, and a disenrollment score, okay? as you can see on the slide, we're using these 4 methods, and what I'm going to do next is review the different approaches that we're using. Next slide. The engagement and planning tool. The tool that was adapted, this tool was actually adapted from Janet Walker's, the Youth Self-Efficacy Scale of Mental Health and the Youth Participation and Planning Scale. We adapted it by not changing the questions, but reducing some of the questions. We were very cognizant of the need to make it a shorter tool for our participants. We use, the purpose is to, the 2 critical dimensions of is to measure the 2 critical dimensions of satisfaction, engagement, and feeling empowered. This tool allows us to track both factors. And we implement it using SurveyMonkey for true anonymity because these questions are related to how well the transition coordinator is working with, how well the engagement is with the transition coordinator. It's completed 3 times a year, and young adults are encouraged to complete the tool. So we get about 48 to 50% of young adults completing the tool. Next. So a next measurement that we use is addressing needs. Addressing needs speaks to the core of what is the purpose of the program. This program is all about developing skills, allowing young adults to do the best of their individual abilities, accomplish a level of self-sufficiency and health as adults. We use the domain, so we use a domain approach. We track 10 domains of functioning. They include things like mental health, well-being, employment, education, living situation, and the young adults actually determine if they have high needs in particular areas. It ultimately doesn't matter what we might think. What matters is what they think, and because what they think they have high needs in is what they're going to actually work on. Needs are identified during the development of the first domain-based plan of care, and they're rated, and the ratings are from 1, needs not being met, to 5, needs is met, to young adult satisfaction. The growth in these in need accomplishment is evaluated by the young adults every month, and the ranking is indeed a perception that is reported by it's their perception of how they're doing. If the young adult does not perceive any progress, we talk about it. The strategies to the accomplishment are reviewed, and even the actual needs may be addressed. It may also be that the need or the goal is too large, and so we will encourage it to break it down or simply change it if it's not working. Most important to realize here is that we never work in more than 2 or 3 needs at any given time. It is too overwhelming, and it can be objectionable if there are too many. Next. The domain appraisal tool, again, I mentioned earlier that this is a tool that is adapted from the NOMS. It formally addresses the big ticket items that are not only important on an individual service level for the youth, but is exceedingly important to our community stakeholders. And those include employment, housing, socialization. That also is aligned with, should be aligned with the needs identified on the plan of care. This is kind of like a cross-check, that if it's not aligned, it's an opportunity to address and discuss and understand what are the personal barriers to even addressing these potential needs. As you can see, there's a lot of usage on the system level for the outcomes of this. It monitors functional needs and employment, education, housing of interest to the community in aggregate form. Next. disenrollment scores. The score is a composite of 3 different elements of disenrollment. They include, has the young adult disenrolled, yes or no, and they will get a score related to that. Average need ranking based on the number of closed needs. So we keep track of the needs, and then we identify what their need ranking was at the time of disenrollment. And there's an average, and each average is allocated a score. And then the disenrollment progress report, which is how one feels about the growth they have made. This is used on a variety of levels. It's obviously for service level. It reviews the personal accomplishments for the youth in the family or the young adult in the family. At the organizational agency level, providing feedback to wraparound and care coordination agencies. And at the system level, because it provides data that certainly can be advertised and used as marketing and as communication within the community itself. Next. So these last group of what is working is measuring outcomes at a system level. These are the big ticket items, education, employment, tracking of negative symptoms, homelessness, law breaking, drug usage, hospitalization. This is material that our stakeholders are very, very interested in, and we are accountable to that. Our ability to track this information is related to, speaks to the power of a good IT system, allowing us to pull information from any and all stakeholders without adding more burden to the young adult. All data is entered into the young adult's medical record as part of working with the young adult, but then can be pulled out to respond to generalized questions by a whole array of aggregated useful information and reports. Except for the DAT, which we do give, no additional assessment tool is necessary to gather these system-level outcomes. Next. So that essentially covered all the tools we were using, I'm going to apply Janet's use model as guidelines for determining what data one wants or feels is necessary to collect and as the best kind of data. So I retrospectively evaluated the measurement and the methods we apply to Janet's model. So what is overall useful? Fidelity data, which we see as greatly important, assures that we are evaluating the intervention model we hold as best practice, and that's at an agency level. Keeping track of individual outcomes to support growth and individual accomplishment at a service level, and data related to big issues of interest to the community at a system level. Okay, next. Okay. So we use essentially what's unobjectable is we try to use SurveyMonkey to maintain an anonymity. We already spoke about that. We choose to complete the DAT privately and independent from the transition coordinator whenever possible. And we limit the number and frequency of assessment tools required to fill out. We use 3 tools. The DAT, once every 6 months. The engagement and planning tool, once 3 times a year. And one tool, the disenrollment progress questionnaire, which is really 2 questions at the end of the program. We actually have asked ourselves and have struggled with the concept of making things unobjectionable or preventing them from being objectionable. We essentially use these 3 tools so that we feel that this is a reasonable amount that does not upset or frustrate our young adult population. Next. Efficient. The structure side of efficiency is the ability to gather information from medical record without redundancy. And so that's the structure side of efficiency. We pull data from billing, from progress reports, from critical incidents. Everything that goes in that medical record can be reorganized and data pulled to efficiently pull in questions out and get responses to questions that we have from an outcome point of view. The process side of efficiency is the use of the domains to guide young adults' prioritization process and the ability to translate these domain needs into goals, which are then followed by strategies and benchmarks on the plan of care. Young adults can see the connections between the desires and growths and improvements as well as can track their progress. Individualization of needs by ranking what they want to work on and tracking them within the framework of plan of care and the meetings is the basis of what we consider an efficient system. Next. So Janet spoke about sustainability. All of the data that is collected is sustainable because it is interwoven into the daily operations of working with our young adults and is included in the medical record. All data is sustainable in addition to this because it is built into the fabric of the expectations established for the contract agencies via the APR process. So they have expectations, they know exactly what they have to do, and it creates the ability to be sustainable because it's from agency to agency, from one year to the next. The only area that I see that needs to be watched is the use of SurveyMonkey as a platform. This is less automatic. It requires an outside person to provide the link 3 times a year, and thereby rendering it a little more challenging. I'm hoping for new technology at some point, either that which that will be developed and that which we can afford, that will maintain the anonymity that we expect within a system that is much more automatic. So I would see that as a weakness, but yet we charge on. Next. Okay, this is actually the last slide, and just to finish it off, we know it's important to stay on top of what we are doing and why we are doing it, remaining conscious and of testing our theory of change helps with focus and clarity of purpose. And that is the end.
Well, thank you, everyone. I want to thank our presenters. We do now have a chance for some input. And for some questions, and so I'm going to go ahead and moderate that, but just really direct these to our presenters. We've had several of them come up so far, but just to remind you all, you can submit your questions now through that chat window that you have down there, and we'll read them back to the presenters. And if, as often happens, you're driving home tonight or later on think you have a question you forgot to ask, please feel free to send the question to us at CMHIeval@westat.com, and we'll get it to the presenters and get it back to you. One other just quick bit of housekeeping. This has been or is being recorded and it will be sent to all the participants who have logged into this presentation, so you'll be able to go back and look at it again. So we do have a few questions that have come in while we've been waiting here. Several of them came in while Nina was talking, but I think others could also respond. So one question is, are you looking at length of services?
Length of service? You mean
yes.
Length of time that youth are in the program?
I would assume that's the question, yes.
Absolutely. We track it all the time. If you look in our article, in the article that was published in Focus, the last time I looked at it, our length of stays are anywhere from 2 to 28 months, and the average is about 18 months.
Great, thanks. And I think probably a related one is, how do you know if there's been adequate dosage and intensity of services?
Adequate dosage and intensity is on our APR. It tells you how many times, how long they have to be, how many times you meet with the young adults, how many plan of care meetings you have to have, how long they have to be. There are definitions for every piece of that. So that's how we monitor it. And those are determined by what we consider best practice, or what has through our years of working with youth and young adults have seemed to be most adequate for what we're trying to achieve.
Great, thanks. And this is a question that uses a phrase that's probably only come into the lexicon a little bit ago, but is apparently quite common, which is, do you sometimes get ghosted by young adults?
I'm not sure what you mean by that.
Well, ghosted is when you, go ahead.
That would be when suddenly you have no contact from a young adult at all, despite reaching out to them.
Oh, sure. Oh, yeah, of course, and we track that, and we have, and off the top of my head, I cannot tell you, but we keep track of what our retention rate is, and so we actually have three types of youth: those that successfully disenroll from our program, those who request to leave the program. For a variety of reasons, and we actually consider that an official disenrollment, and we measure their level of success anyway. And then we have the youth that run away or disappear, and we do not close out for a very, very long time. We continue to try to call them, respond to them. And sometimes for a period of up to 6 to 8 months at least. And there's no guideline that says we have to cut them off or disenroll them from our program. We just keep trying until the professional judgment of the transition specialist says it's not, there's no point. But they're always welcome to come back. We tell youth that, and we do have like a 5% return. Some youth leave for no apparent reason, and then all of a sudden they show up on our doorstep again, and we welcome them in at any time.
Great, thanks. We have another kind of specific question, and then there are a few other more general ones. This one is, are there incentives to complete SurveyMonkey, and if so, how much? What is the incentive?
We do not use incentives at all. I mean, we use them for other things, absolutely, when I'm trying to get specific data or if I'm doing special interviews, but as a regular ongoing method of incentivizing young adults to do this specific, our evaluation, our engagement and planning tool, we do not. It is set up as an expectation from the beginning.
And here's a somewhat broader one. How can evaluators ensure that questions are culturally appropriate for youth being served? I think several of you could address this one. All of you could.
Well, sure.
Yeah.
I'll take a crack. I mean, I think that the place to start, obviously, is working with the young people that you're serving to see what they think of the questions, because we can think of culture along a lot of different dimensions. I think it's very difficult to anticipate how your particular population of young people is going to perceive specific questions, specific usage, et cetera. So I think that if you haven't developed your evaluation strategy in consultation with your young people, then you might want to reconsider and do some of that. Mary Beth, do you have anything to, I see you nodding your head, you want to add anything?
No, I just agree with that. It's really important to pay attention to what the young people are saying and think is important as well. And, well, like you were saying, what would it mean by culturally. So you want to figure out what cultures you're trying to be responsive to, and then, you know, go from there.
Yeah, I think overall young people are kind of sort of in the middle of a Venn diagram of lots of different cultures, including peer culture, their culture of kind of family origin, youth culture, and various other affiliations that they may have chosen. So it can be very tricky when you have, especially you might have a very, very diverse group of young people.
Yeah.
Great, thanks very much. And also a comment that's also general, which is comment on the degree to which and how program partners such as young adults, clinicians, administrators are involved in determining evaluation indicators and processes.
Our indicators, our APR indicators, are discussed with every agency, not as much with youth. Because really our APR indicators are related to fidelity to the model, to the program, and but that being said, not that I think they could benefit. I think we could benefit from doing some of that for sure, or more of that actually. But in terms of folding in our care coordination agencies and individuals that are delivering the program, we absolutely include them in revising them, reviewing them, creating new ones, and we just went through that whole process in the last couple of weeks, actually, a month ago, and involved a number of people in that process.
Thank you. And another question that's also general is, other than getting feedback for improving services, how can evaluators encourage engagement from staff in data collection?
Well, at the risk of repeating myself, I mean, I think we did discuss some of these things. I think that keeping the burden to a minimum, if staff feel that what they are gathering, the data that they're gathering is being used and useful, and if they don't feel embarrassed because the questions are clearly kind of obnoxious to young people. So I think that all of those things can help with improvements and engagement of staff.
Thank you. And there's also a question, is the DAT available?
Is what available?
The DAT.
Oh, yeah. Oh, sure. Sure. I'd be glad to. I see on the board here. Be glad to share it with anyone. They just need to write me. It is not so that unusual. That it doesn't deviate so much from the NOMS. It's just a little bit shorter, and the time frames have been adjusted a little bit. But I'd be glad to share it with anybody who just requests it.
Great, thank you. And then we've got a few others, since we have a little bit of time. This one's really for Mary Beth. Do you remember particular assessments or types of assessments that you really didn't like? And have there been assessments that you felt really okay with or liked participating in? What would distinguish those two types of characteristics of assessments for you?
I'm not sure. Okay, so kind of on the spot, but as I'm thinking about it, I mean, I feel like I've talked a lot about the suicide question on all of the assessments, so that has always been a tripping point for me. Having quick assessments, for me, it's not necessarily about the assessment itself. It's more about the supports during the assessment. So things like having a snack available, having like that, literally granola bars, like very basic type stuff is really helpful for wanting to engage. Having fidgets available, that could be anything from like a piece of rope to, I don't know, rubber band. Being able to take breaks was super helpful for me because, like I said, these were really long assessments. And so that was helpful. And besides that, for the most part, I was pretty willing to be honest on assessments, although I didn't deal with for me, a lot of my stuff was very mental health based, not substance use based, so I didn't feel any stigma around all of that. So you're getting a very individual perspective from me. But having supports in doing the assessments is what was helpful for me. So that was literally, I was meeting with a person who was asking me the questions and willing to fill in the bubble for me, because I hated writing at that point. Or I could give my answer and she would write it down, kind of a thing. Because again, I hated writing. So that would have gotten less good data from me if I was the one that had to write it down. So having supports with giving the evaluations and assessments is the main thing that made it more doable for me. And also incentives, honestly. That got me there. Otherwise, there was no way that I was putting time towards it.
Thank you very much for sharing that. I think that's really helpful for people. So really kind of for Nina, but the amount of data that OEA collects, it's a lot. It seems like a lot of data. How do you manage to do that? How do you manage to pull that off?
So I kind of anticipated this question. The truth is that this, first of all, if we think about, it's 10 years old, and we've had a long period of time to develop tools. And then it's based on and sits on the shoulders of wraparound, which has been in existence since 1994, I believe. So none of this happens. None of it happens immediately. Nobody can sit down and say, we're going to do all of these things all at once. It's overwhelming. It's impossible. It takes too much person power to do it. It can't be done. What can be done is that people start looking at their highest priorities of what they want to know and why they want to know it. Why is it important? What is it? Because it's part of your belief system. Because it will give us a sense of direction of where we go next. Whatever the reason, we need to be accountable to our larger stakeholders. Whatever your reasoning is, that you pick a few and you start building on the process. Our result is years and years in the making, and it's even for us, it's a never-ending part. It's a never-ending business. We could turn around in a years from now and say, we're not getting the results we want out of the DAT, and it's too time-consuming, and the youth and the young adults don't like it, and they're resisting using it, and then we have to look around and try and look for something else. So I guess the answer is that you start small. You start with good targeted objectives in mind, things that are necessary, not just, it would be interesting to know, but stuff that really makes a difference in how the program will evolve and progress, and start there and just you build on it. It doesn't happen all at once. And a lot of the data is doable because of our IT system that we have, where we're not asking a lot of too many people except to complete the medical record as needed as part of the job. And then the data is then pulled from and aggregated and organized to answer some questions that we need.
Great, thank you very much. And then just sort of some follow-up about how to get more access and more information from the Pathway Center, Janet. What's a good way to get access to things like focal point in the assessments that you mentioned and get more information in general?
Well, the easiest thing is to go on the website, and we do have a web search bar up at the top, so that might be the first way to to look for specific things. We have tried to set up the navigation so it's pretty easy. We have all of our publications. We have our featured publications. There's this, on the navigation is, you can go directly to Focal Point that way. And I would encourage you, if you know, obviously people who are on this webinar are interested in the population, to just browse our featured publications, and we have recordings of webinars and various other resources as well.
Great, thank you. And one more question I think that we'll ask, given our timing. We have one more. For anyone on the panel, any suggestions for encouraging leadership to get behind evaluation that goes beyond the level of meeting bare requirements of the grant funder? This is someone speaking in part of programs that do not come with built-in evaluations or evaluation requirements.
Well, my suggestion would be kind of to be strategic. So first of all, to engage your young people, I feel like if you can get a meeting with your funder or whoever it is that you're reporting to point out, so you do your homework, you figure out what are the efficient indicators that we'd like to be collecting, why are these important to our young people, and then bring them with you and perhaps other stakeholders as well. It's hard to look your clients in the face if they have a really well-reasoned, well-thought-out request and say, no, we don't want to do that. So, you know, once you've gone through picking what's useful and efficient and how you might, proposal for how you might do it, and then trooping into the office of the head honcho or the management group and asking in a very civilized way for some discussion. I think that's often a good way to proceed.
And I guess I would add by saying use the data. You know, just don't report it once, but really whoever is generating the data ultimately, or is writing the summative report, that they need to be an integral part of the program team. And for that to happen, you need to be able to bring forth that data and saying, what does this mean for us? And how do we use it to improve what we do? How do we change what we're doing based on the data? I think that the more you can use the data, the more people will buy into collecting data.
Well, thank you. Thank you very much. And I want to, on behalf of the CMHI National Evaluation Team, thank Janet, Mary Beth, and Nina for a terrific presentation. Thank all of you for your great questions. Again, if you have any other questions, feel free to send them to us, and we'll make sure they get to our presenters. And I also want to call your attention to our next webinar, which is going to be on how to analyze Medicaid data to inform quality and cost improvement in systems of care. That'll be Thursday, July 25th, from 1:30 to 3:30. We hope many of you will be able to attend that one. And otherwise, again, thank you to our presenters for a terrific and informative presentation. We look forward to seeing you on our next webinar, and have a terrific rest of your day. Thank you very much.
Bye, everyone.
Thank you.
Thank you.